Hi everyone, and welcome to the Emergency Medicine Clinics podcast. I'm Jo Collett, the managing editor for the series here at Elsevier. Emergency Medicine Clinics is a quarterly publication consisting of review articles focused on a central topic. Today, we will be discussing the August 2021 issue on Pediatric Emergency Medicine. Joining me today are Drs. Mimi Liu of the Department of Emergency Medicine, Department of Pediatrics at UCLA, Eileen Claudius of Department of Emergency Medicine, David Geffen School of Medicine, also at UCLA, and Christopher Amato of the Department of Emergency Medicine, Goryeo Children's Hospital, and Morristown Medical Centre, Department of Emergency Medicine and Pediatrics at Sidney Kimmel Medical College. Welcome all. Let's jump right in and look at the first highlighted article from your issue, titled High-Risk Medico-Legal Conditions in Pediatric Emergency Medicine by Drs. Michael B. Weinstock and Heath Jolloff. Can you share some highlights of this article with us?
So this article for me was, as usual, anytime I come across a high-risk medical legal chapter or book or review or article, it's always eye-opening and incredibly humbling. I mean, we find ourselves swimming in a sea of worried well, and somehow we have to tease out the complexity of the high risk condition that puts us at a higher medical legal risk, right? What's interesting about this article is the most common reason for paid claims in pediatric emergency medicine was an error in diagnosis, accounting for 51% of paid claims compared to 39% of paid claims in adult emergency medicine. And this article kind of breaks down a couple of the categories I think intuitively we know. One, the straightforward, well-appearing infant that's ready for discharge before you ever see them. The sick, which is not the high-risk legal one, because you know that they're going to get admitted and they're going to get aggressively worked up. But really, it's the ones with diagnostic uncertainty, the ones where we are at higher risk for errors in diagnosis. We know that we have patients that masquerade with benign disease representing big risks to misdiagnosis, ED discharge, and ensuing, as this article refers to it, as legal misadventures. Somehow we're supposed to thread this fine needle between the risk of missing serious disease and the potential for harm, expense, false positives. And we know that kids provide a limited history and physical, especially in pre-verbal children. And we compound this by the fact that pediatric patients present with subtle findings of serious disease like tachycardia and myocarditis or sepsis, the intermittent well-appearing child and intussusception. The article goes on to offer a nice 2-minute legal primer on just what conditions establish malpractice, all 4 elements: the duty, the breach of duty, the fact that there was harm, and the harm was caused by the breach of duty, or causation and proximate cause. What I found interesting was a review of the claims by the Physician Insurers Association of America, database between 2001 and 2015. The 5 most common causes of pediatric EM malpractice were cardiac or cardiorespiratory arrest, appendicitis, disorder of male genital organs, encephalopathy, and meningitis. What I appreciate, though, is this article did a deeper dive into things, high-risk conditions like acute appendicitis and torsion, with opportunities for improvement, common factors in misdiagnoses, understanding that no findings definitively diagnose or exclude appendicitis. Lab findings are neither sensitive nor specific, but ensuring good patient and family understanding of the uncertainty and strict return precautions that are time and action specific are key elements in enhancing opportunities for improvement. For example, pain that's still persistent after 8 to 12 hours, because fewer than 2% of patients with appendicitis rupture at 36 hours. So an 8 to 12 hour time window for follow-up is reasonable, but the standard 48-hour time window for follow-up may be too late. Now, for some of us in our ED prolonged wait times, that 8 to 12 hours is discharge and turn around and register right back in again for that second exam. Is anybody else having that issue? In addition, this article provides a nice glance at metacognition and how we really need to monitor our own thought-making processes and realize when we're most prone to error. If errors are appreciated, employing what they refer to as cognitive debiasing and trying to avoid falling into the trap of cognitive dispositions to respond, that kind of thought-making shortcut that we've all been conditioned and trained to do in a busy emergency department. The article goes on to talk about EMTALA. It talks about consent of minors and involuntary holds, which are largely state-specific. And it even has a powerful story with an excerpt from an EM physician revealing the deep hurt that can ensue after an adverse outcome and the subsequent trauma on a personal and familial level, leading to thoughts of suicide. The article ended with the top 10 clinical points to decrease medical legal risk. And, three of them really struck a chord with me. One is using the medical decision making as a hard stop before completing documentation. Ask yourself, does it make sense? I once heard a phrase, dance like no one's watching and chart like it may one day be read aloud in a deposition. Would you be comfortable defending your care to the family, the chair, peer review, or even to a jury? If not, reconsider. Maybe you need more additional testing or history or documentation. Number two, aftercare instructions need to be time and action specific. And finally, don't practice defensive medicine, but evaluate and document in a way that is defensible. I think these are key components in helping us to reduce our overall medical legal risks in this challenging environment. Chris and Eileen, I'd love to hear your thoughts on the article.
I thought the section on testicular torsion was really practice changing for me. I know that you're supposed to do a GU exam in boys who have abdominal pain, but you got to remind yourself, and after you do 10, 20 negative GU exams, sometimes it's easy to let it slip. This article talked about 1/3 of patients with testicular torsion presenting with exclusively abdominal pain. So especially in those teenage boys, those kids that really, really don't want you to do the GU exam, those are the exact kids that you need to remember to do it in.
I couldn't agree more. I actually will have a running dialogue with my residents and fellows that if they did not check the testicular exam on a male patient that's coming in for abdominal pain, I ask them for their wallet, and they have to hand it to me in at least pantomime to just underscore the importance of the genitourinary exam in males, because it absolutely can masquerade as right lower quadrant pain, and you go down one track and you anchor down there looking for appendix, and you are losing time, and we all know that time is testicle. I think that the article actually was a wonderful summary of all the things that we do every day without necessarily putting a clear idea on. And it does come down to the concept of what kind of physician are you? Are you a test minimizer? Are you a risk minimizer? And irrelevant of how you approach pediatric care, it is important that your documentation does at least indicate what you were thinking, why you did what you did, what pretest probability questions you had that those tests or radiographies helped to solve. And then if you're fortunate to work in an institution that actually has very close ties to the local physicians, having that discussion with their primary care, hand that patient off afterwards. It's so easy to be fooled by children because they are, as you indicated, just nonverbal or really they lie. Let's just put it that way. They don't tell us the truth that we want. And as it indicated as well, the labs looking for appendicitis are what's going to lead you astray, irrelevant of what a surgical resident might say to you. The cognitive dispositions to respond, I thought was very interesting from the Canadian government, looking at something akin to Malcolm Gladwell's concept of blink, right? Once you've done 10,000 hours, or in our world, 50,000 patients, you can get some kind of insight perhaps, but it's very easy, as you just indicated, to dissuade yourself from, well, it's probably going to be negative, I don't have to do that. But consistency is going to be crucial to good, solid patient care. And I think that this article is a very important reminder of all the things that we probably do, but probably could always get a little bit better on.
Okay, thank you. Let's move on to another article which stood out to you. Neck trauma by Doctors Nicole McCollum and Sabrina Hughes.
So I think that this is a really important article in the sense that the change of location of where the injury occurs in a child is so much more dramatic and so much more potentially life altering. Not that anyone with a cervical spine injury is going to be in a good way, but in a child, you're talking about a cervical injury in between C2 and 3, as opposed to over 8 and more adults, you're talking between C5 and 6. If we go back to the nexus criteria, we can look at similar things can predispose a child to injury, but more often than not, most children are not inebriated when they're having their neck injury. At least we certainly hope not. They're going to be susceptible to the same type of cervical spine injuries that adults are, but there are going to be a few things that are much more specific to the pediatric population. Atlantoaxial rotary subluxation, pseudosubluxation, which is something that you have to have seen to know that you're not missing something that's injured. That's typically on that C2 and 3. And then spinal cord injury without radiographic abnormality, or the acronym of SHWARA, right? We talk about atlantoaxial rotary subluxation is typical when C1 will rotate onto C2 after an injury, specifically to the ligamentous processes. So this is not a bony injury, this is actually a ligamentous injury. You not necessarily can diagnose this clinically, so you have to have a high suspicion. And in about a decade ago, PCARN came out with, again, a list of specific physical findings that should put you at a higher risk, or at least at a more conservative approach to the patient presenting with cervical spine injury. It's really, as we've already indicated with the prior article, it's very difficult to make this assessment in a child. And in fact, actually, there's not enough literature or data in the toddler or younger group, because there just isn't a very common injury. This is only 1% to 2% of all pediatric trauma combined, which is wonderful because, again, it would be a much more devastating injury. Nonetheless, it is hard for you, the clinician, to approach this younger child and have a deep sense, or at least a comfortable sense, of knowing who should be evaluated for cervical spine injury, whereas who should not. Much like adults, if it's a high-risk injury, certainly diving or et cetera, or a high-risk motor vehicle accident, we're going to be concerned. Again, the PCARN process will give us a little bit more information about what we're looking for when it comes to clinical diagnoses, if there's torticollis, if there's any findings that seem indicative of chest trauma, and it goes on further from there. So we as clinicians need to be a little bit more judicious in the approach to these children, and certainly considering of the radiation that we're exposing them. We don't want to take the pan scan approach to the pediatric patient, because we already have now clear-cut literature that dose-dependent radiation exposure, ionizing radiation exposure, is fraught with problems along the way, in the sense that there's a higher development of lymphoma or even brain mass, depending on the locations that's being exposed to the ionizing radiation. I think one of the other things that it touched on very well was talking about the blunt injury and vascular injuries related to that. You're not going to get the typical findings that you can see on the adult patient with a seatbelt sign. You have to have a little bit more of a suspicion with this child. Just a couple of hours ago, we had a child that was wearing a belt and not a 5-point harness, and the child was 3. So that's a completely different conversation to have in terms of appropriate restraints. But on my ultrasound, the child clearly had fluid around the splenic area. So we wound up getting the abdominal CT and mobilizing our trauma service for that child. So utilizing our ultrasound experience, utilizing and understanding that it's only about 66% sensitive for fluid in a child, because you do need a bit more fluid in that intra-abdominal cavity to find it on ultrasound, is important to understand. But also just the clinical scenarios that are going to put a child at higher risk are also going to be crucial. And I think this chapter did a very good job going over the things that we as clinicians need to be cognizant of when we are evaluating these pediatric patients.
Yeah, I always find that question of cervical vessel injury from blunt neck trauma a really tough one, because the indicators for adults having cervical vessel injuries don't really have a lot of support in the pediatric data. So I loved this discussion and the mention that the isolated seatbelt sign in a child is not a compelling indicator of who needs further imaging for pediatrics was really, really well done, and I thought needed to be highlighted.
Absolutely. I agree with Eileen. Other things that I think were interesting that this article brought up is bring back the radiograph. Like, when's the last time you got a plain film on an adult patient with a neck injury? I once talked to a pediatric trauma surgeon. He was kind of like, kids don't really need cervical collars. They will splint themselves. They will protect themselves. If there's an injury, you'll know it. But This article brought up the idea of skiwara, and that even with a normal neurologic exam, normal radiographs, normal CT scan, you can still have this injury. And the onset of neurosymptoms can be delayed up to 48 hours. So that a normal neurologic exam immediately after injury doesn't rule it out. And, I was always taught, find that focality. That's what makes, a patient high risk, needing further imaging, needing further evaluation. So it's just a reminder that although rare, it's still something to consider. This article also mentions palatal injuries, and I always have a hard time figuring out when I image these kids with a stick up their snout, right? Like it's impaled there, they're not hemorrhaging, it's such a tiny entrance, but do I need to image, and what are the factors that go into it? And the distal propagation occurs from a period of 3 hours to 60 hours. And there's this concept of a lucid interval clinically between when they show symptoms and the actual thromboembolic event. So I don't know if it was reassuring or not that the literature is all over the place as far as how to manage these palatal injuries.
I think that's an awesome point, Mimi, and thank you for bringing that up. I completely blanked on that actual aspect. This point was made salient to me early in my career when a child came in for an evaluation of, the classic popsicle stick that went through the soft palate and the posterior pharynx. And at that point, young in my career and ignorant in my ways, I discharged the child without any evaluation, no soft tissue neck x-ray, no antibiotics for prophylaxis for possible mediastinitis. And within 24 hours, the child came back with mediastinitis. So I do think I'm a little bit more conservative now in my approach in that. And even if it's something as simple as a coffee stirrer, and again, what is a 2-year-old walking around with a coffee stirrer in their mouth? I am a little bit more aggressive in that just because experience is my guide in that respect. But thank you. That was a really great point to bring up.
Chris, clearly the 2-year-old is getting their flat white latte with a vanilla flavoring during their Starbucks run. Come on.
100%. Yes. That's for our Seattle listeners.
The best is when they have the coffee stir in their mouth while they're jumping on the trampoline. That's my absolute favorite. It really combines that childhood experience with that more adult latte.
Kids are little adults. Do you find yourself having a very low threshold for the CT angio of the neck then?
I will say no. I'm going to start with the x-ray first. If I see subcutaneous emphysema, I will reevaluate and have a conversation with the either my ENT or even my thoracic people, which is relatively uncommon, to be frank. That's a wonderful question. Honestly, the only time I'm really getting more aggressive with CT angio is when there's true trauma involved. We have a lot of falls from horses here in New Jersey. And so more often than not, I'm concerned with the twisting injuries that they've had. And I fortunately have only had one child with a vertebral artery dissection from that incident. So it is not a common thing in my world, and that's a lot of radiation, right? I mean, so I would rather have that conversation with the subspecialist or even park that person in the unit so they can have quicker and more frequent neuro checks. What about you guys? What do you guys have experience with?
I don't do a ton of CT angios. When it comes to the penetrating injury that we were talking about through the oropharynx, I work pretty darn hard to try to see the base of that injury. And if it's right on the midline, especially if I can see the base, or if it's off the midline, but I can clearly see there's a shallow base, I don't study that any further. I mean, it's not going to take out your carotid if it's right in the midline. I might give them an antibiotic to prevent an infection. And if it's off the midline, but I can see that there's a very shallow base, I don't necessarily image those kids routinely. I agree, though. It's pretty rare that I'm doing a CT angio on a blunt injury. Obviously, if you have a major C-spine fracture, dislocation, then I am, but those are so uncommon in kids that they have to have some pretty impressive neck trauma for me to be taking that route.
Again, this is another one of those cases where we have a rare process, but a high risk condition. So I agree, low threshold for antibiotics, even though I would argue the literature isn't that clear on it, but I think it's absolutely reasonable. And when you're talking about rare but catastrophic sequelae, 1% of penetrating injuries, I mean, 1% is kind of our threshold for a lot of things, cerebral edema, right? And things like that. So I never needed to treat. I don't have an exact calculation, but I'm not sure that that's worth the risk of radiation, possible sedation, contrast load, everything else that a CT angio would entail, unless I have a really high risk. Unless I have a really high suspicion.
And
Agreed.
contrast. You have to also have contrast, which I would love to give somebody a high contrast load right now.
Just talking about the national shortage, are you?
Another article of note in your issue was Cardiac Emergencies in Kids by Doctors Ashley and Strobel and Lean Alblayed. What were the highlights of this article in your opinion?
So we don't see a lot of pediatric post-surgical cardiac patients or ventricular assist devices at my ED. So I certainly read this one a few times because a lot of it is material that I just don't review every day in my patient care. They talked a little bit about all cardiac lesions that are surgical, which was a great review, but they really got into depth on the 3-staged palliation of the single ventricle patient. So this applies to children who have pathology where they effectively have a single functioning ventricle. For example, those with hypoplastic left heart syndrome. These kids typically undergo a staged palliation with surgery initially at birth, a second stage at 6 months, and a third stage around 2 years of age. And kids have unique exam findings, unique oxygen saturation goals, and specific complications at each of these stages. So these intra-stage children between the first and second stage, between the second and third stage, after the third stage, they're all completely different. And all of that information is very relevant to the emergency physicians that are assessing these children. There's also a few features of these pathologies and of the results of the palliation that alter the care of these children when they are presenting with non-cardiac problems. So presenting with a simple viral illness, presenting with dehydration, or presenting with a peri-arrest state, they're going to be managed differently than children who have not undergone these procedures. Finally, ventricular assist devices, including setting, complications, troubleshooting, they're summarized very clearly, even for someone like me who almost never sees these. And there's an in-depth explanation for providers wanting more information because they are in the position of managing them frequently. What did you guys think?
I thought it was a great review. I think that we all got a little bit lazy talking about Norwood, fenestrated Fontan, and those are terms that are easily, for me, forgotten because it's just something that I remember from pediatric residency where we actually did do post-op hearts. And then during chief residency, I was in charge of those patients post-operative and terrified all at the same time. I did appreciate the fact that this chapter, as many of the other ones that we discussed, really do focus on trying to involve the caretakers, the parents or the guardians about what is normal for your child. And I think as clinicians, we really do need to reiterate that importance of having those questions asked to the family members about what is their normal pulse ox, what is the normal, even blood pressure. And these families are amazing about how much they know and how intuitive they are with their child. So I think that one of the things I always try and remind my residents and fellows is that you always listen to the mother. You can probably ignore the father, but you should always listen to the mother when it comes to them telling you something's off with their kid. And someone who's got the degree of surgical interventions as a single ventricle does, or the mechanical complexity of a ventricular assist device, you really do need to be cognizant of maintaining their hydration with fluid boluses and preload, not getting freaked out that you don't feel pulses when you're examining them. It really is a completely different clinical scenario than we are used to as clinicians because their anatomy and physiology is now affected by the instrumentation that they've gone through.
Yeah, there's a couple of patients that I categorize as being really cautious and gentle with IV fluid. And certainly these complex congenital cardiac kids fall into that category, in addition to neonates and children with sickle cell disease. Just being almost overly cautious with fluids. It's always easier to add on than it is to take away in these tenuous patients. I also, thankfully, don't see these that often, certainly not when I was out in community practice for over a decade. But, patients with LVAD exist, adults, pediatrics, and it was a great review and opportunity to kind of think about how to troubleshoot an LVAD, because inherently there's the sphincter tightens, it's a high intensity situation when I'm dealing with a crashing patient with an LVAD. But there are certain things that I reminded myself not to do in patients with an LVAD. Don't do an MRI, don't do thrombolytics, and don't manage this by myself. Thankfully, most of these patients are really well connected to their providers, and you kind of figure out how to stabilize them while you're getting help. Little tips like not hearing a murmur is probably a really, really bad thing because there's a thrombus somewhere. Can you defibrillate? Yes, you can. Can you do CPR? Yes, you can. Should you do a CPR when the Doppler map goes below 50? Yes, you should. So there's certain great reminders of like how to manage these patients while I'm temporizing them until I get more definitive help and care.
I remember managing these patients as a resident as well. And we had a very heart surgery heavy NICU and PICU where I trained. And my orientation at the very beginning of my second year, our first NICU rotation was, here is the bone cutter. And if one of these patients crashes after surgery and you need to cut open all of the bones to expose the heart and save this child's life, here's the glue to put it back together. And the surgeons are going to be really mad at you if you don't glue it back together. I have to say, this article made things a lot clearer for me. I found this a lot helpful than my initial introduction to management of the post-surgical small cardiac patient.
Did you ever have to pull out the bone cutter?
I did not, but I did not make a lot of friends that day because this was the peds half of my residency, right? And so all the other pediatricians are very politely sitting there trying to pick their jaws up off the floor, because this is also our first NICU rotation. We didn't do it as interns. So not only are we being introduced to the 24-weekers that we're going to be dealing with, there were no in-house fellows, no in-house attendings. It's literally just you, but we're getting this lecture on our post-cardiac patients. So I raised my hand and I said, if I manage to identify the problem, reopen this child's chest and save the baby, I think I'm going to leave it to the cardiac surgeon to glue it back together. And they got very angry at me.
I think that's absurd in this day and age. One, clearly they had to be filming you because that has to be something that they get together and just enjoy, like, got you on camera kind of thing. But that's absurd. I can't even imagine that. I do remember being handed the box that was attached to their heart after the OR, and the first thing was to cool them down as quickly as possible. Cool down, Chris, cool down. And then I was like, okay, I'm holding a box that can affect their cardiac function. This seems like the worst kind of Nintendo game I should ever be handed ever.
I'm gonna really revel in my orientation where somebody just handed me a tube of refeed and asked what I wanted to do with it. And I said, ew, gross. What do you usually do with it? And they said, give it back to the baby. And I said, ew, okay, sounds good. No bone cutters, no Nintendo games, none of that. So I'm very appreciative of my NICU rotation.
All right, solid article to help all of us through, and obviously revisit our traumatizing moments during residency.
Right, it was informative and therapy all at the same time.
There you go.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue that we're discussing today by visiting us.elsevierhealth.com/expert.
We've selected an article on technology-dependent children by Drs. Alamelli Natasan and Solomon Bihar.
So this was a solid article that goes over a lot of basic things. I'm going to tell you how old I am by saying this out loud. I remember when there were no PE tubes. children have chronic effusions in their ears and actually have altered phonation of speech because, as we all know, the eardrum is responsible for about 30 decibels or almost 1/3 of your hearing. So if you have constantly got fluid behind your eardrum and it doesn't vibrate, you won't be able to hear. So I'm going all the way back. It has nothing to do with this article, but I just want to indicate that these are the subtle and amazing interventions that are occurring by these inventions that are affecting and improving children's lives. So this article goes over the basic stuff from G-tubes all the way towards vagal stimulators and cochlear implants. It's a very important discussion. And I think we as clinicians take for granted the simplicity of something as simple as potentially a G-tube. We think that, patient comes in and the G-tube has fallen out. Quickly, we want to get it back in as quickly as possible. And sometimes if the family does not have a replacement tube to place, we'll just utilize a Foley at either the same French or one size lower. But the replacement of a G-tube on an early stoma, certainly before that 4 to 6 week time period where that stoma matures, can actually lead to a false track and be dangerous to the child. And actually, we had that occur at my institution about a decade ago. So it is important for us as clinicians to recognize even the simplest procedures can be fraught with danger. I like the little tip about putting the tip of the G-tube in ice water before placing it in the stoma. That does stiffen the plastic and allow it to go in a little bit easier. And then it is always important in my mind to get a little bit of gastric graphene or some kind of contrast material and prove that you have it in the correct spot. So I, even to this day, 30 years later, am still doing that post-placement X-ray. And I know that the literature probably says at this point that you really don't need to, but I'm a bit of a stickler when it comes to that because I do want to prove that I've got everything done correctly. In terms of the central nervous system, VP shunts, right? Again, something that we take for granted. In the last 6 months in my institution, we have had 3 separate patients present with a broken VP shunt. And it's not the CT that showed the issue. It was the VP shunt series on the plain X-rays that showed the break in the tubing. That is absolutely an imperative finding, so we can let the neurosurgeons know and get that patient cared for much more appropriately than if we had not gone the plain X-rays. In terms of VP shunts, I think they were all comfortable with it, and we all understand that there was a bunch of complications. Certainly, as a clinician, I don't want to be the one that is tapping that shunt. If I'm concerned about meningitis, I've certainly had a lot of neurosurgeons tell me that they're not going to tap the shunt, that I should just go ahead and do the spinal tap from below, and then it will have a nice conversation that will ensue afterwards in terms of what is the status of the child and go from there. But I think that it is a very good review. This article just has a basic overview of all the basic things that we are dealing with, probably on a daily, if not every other day, event in the pediatric ER. I think that we should also recognize the advancements that have been made, and once again, involve the caretakers about what are the norms for your child. Cochlear implants, much like a PE tube, but obviously far more fancy that it's going directly to the auditory nerve, is an amazing device that is allowing a patient who has never had hearing or had significant sensorial injury or deficit now can actually hear the rest of the world around them. So this is something that can be fraught with infections. And again, we should be utilizing our consultants and our specialists to make sure that we're not missing something that can affect the degree of surgery that was required for this placement. Infection is going to be the most important one that we're going to deal with when it comes to a cochlear implant. In terms of vagal nerve stimulators, I think that that's the last thing, and that's probably the most new. Much like an ARCI with an adult, you're going to have the control utilizing a magnet over that left anterior chest. So you can activate a stimulation of the vagal nerve by basically waving that magnet over that left anterior chest, and you can turn it off by having the magnet just taped over that spot. So if you've never had a patient with a vagal nerve stimulator, this is a great review to talk about what you need to know about how it works. And it has made an enormous difference for these children who have been tried on multiple and myriad anti-epileptic medications with no success. We are talking about a significant improvement in their daily life with dramatic decrease in seizure activities for these children. So overall, I thought this was a great basic overview of typical things that we will see with common pediatric patients that are presenting to our ED and what we should know as clinicians.
I agree. And I think we can extrapolate a lot of these things to adult patients as well. I mean, gastric tube dislodgement, so common in kids, so common in adults. And this is something that can keep you in the ED for a really long time. If consults are needed, it can be difficult to follow up because a lot of times these patients don't really clearly have a home for that G tube. So if we can efficiently and safely replace these in the ED when it's appropriate to do so, we can save so much time for families. We can save admissions, we can save stress, we can get these kids fed through their gastric tube rather than getting IV fluids. It's a great overview and a great reminder. And it talks a lot about the specifics, the complications, the confirmation of placement, like you said. I think this is bread and butter, and we have to know this.
I certainly appreciated some of the advances that were mentioned with vagal nerve stimulators. I mean, there's a closed loop system now that just detects an elevation in heart rate as like an indication for seizure and automatically utilizes the vagal nerve stimulator to try and abort the seizure early on. I mean, the technology, as Chris mentioned earlier, is so advanced and so interesting. I think one of the things that I was reminded of is the side effects that can happen. Voice alteration, hoarseness, sore throat, cough, dyspnea, vomiting, headaches, esophageal spasms, paresthesias. I don't know that I would have innately recognized some of those side effects being a complication or a side effect of the vagal nerve stimulator, and putting a magnet on it, disabling it while you're trying to talk to the generator of the device to interrogate, or the manufacturer. So you basically can take a magnet to turn it on, take a magnet to turn it off, and just temporize. But if they're actively seizing, you throw a magnet on, but you're still handling it the same way we would every other seizure, adult, kid, across the board, right? ABCs and some sort of benzo as you're trying to stabilize them. So that's kind of a helpful reminder of things to think about while we're dealing with these patients.
Thank you so much for your hard work and for guest editing such a great issue, and for taking the time to talk about it with me today. Thank you for joining us for this edition of the Emergency Medicine Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on pediatric emergency medicine, visit us.elsevierhealth.com/expert. Emergency Medicine Clinics is available for individual print subscription with accompanying online access, individual online-only access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. New subscription and single-issue pricing options are also available on the Clinics app. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Emergency Medicine Clinics podcast on Apple Podcasts and the Google Play Store.